which is obviously still in use. No one knew or knows how it works. There have been various theories through the ages, but nevertheless, there was a consensus emerged in the 1950s that somehow it was having a specific effect on the underlying pathology that was causing severe depression or manic depression. So the reason I'm dwelling on this is that in the 1950s, therefore, which was the time when all of the modern sorts of drugs that we now have in use in the mental health services were introduced, psychiatry already thought it had two specific treatments: insulin coma therapy for schizophrenia and ECT for depression or manic depression. And those were the two conditions that structured psychiatric knowledge and diagnosis for most of the 20th century. So the first modern drug that was introduced is usually thought of as the first of the antipsychotic class of drugs, called chlorpromazine. Here it's known as Thorazine, its brand name. It was quickly widely adopted throughout institutions in Europe and here. It was introduced here by SmithKline French with a massive marketing campaign. The CEO of the company went on national television to announce the arrival of this miracle drug that would change the nature of the care of the mentally ill. But this is the two French psychiatrists who first used it in France. But it was first understood to work according to that drug-centered model. It was not seen initially as a specific treatment. It was thought to induce a particularly useful and novel altered state. And so people like Pierre Denneker particularly and Jean Delay described in detail the characteristics of the altered state that it produced. And so their writings contain a lot of descriptions like this of the sorts of effects these drugs had on the patients that they gave them to. So they particularly picked out the emotional indifference that they seemed to cause and the reduced responsiveness, the reduction in initiative and motivation that people seemed to show, and as they mention here as well, a reduction in mental preoccupation, which was useful if someone was mentally preoccupied with abnormal or distressing experiences. Pierre Denneker went further, and he suggested that what these drugs were doing was replacing the symptoms that someone had, the psychotic symptoms, in the case of psychosis, with a new disease or a new neurological syndrome. And the new neurological syndrome was something rather like Parkinson's disease. These drugs effectively cause Parkinson's disease if you put them up high enough. And what he was saying is, before you get to the very obvious signs of physical Parkinson's disease, you're getting mild signs of Parkinson's disease, which is slowing up mentally and physically, which is what's useful. That's what we want. That's what we're trying to achieve. And other people went along with that view. It was a widely held view in the 1950s. But over the course of the 1950s and 60s, that view transformed, and these drugs started to be seen as specific treatments for the condition of schizophrenia. So textbooks start to talk about them doing more than tranquilizing, penetrating closer to the site of the mechanism of the disease by 1960. And by the mid-60s, a big clinical trial of these drugs declares that, which finds them more effective than a placebo, than a dummy tablet, declares that they should be regarded as anti-schizophrenic, and we shouldn't think of them as tranquilizers anymore. You can see this transformation if you look at advertisements of the time. So early advertisements emphasize the tranquilizing properties of these drugs. They also emphasize how they can be useful in many different situations. So they were widely marketed for agitated behavior in the elderly. They were widely marketed for childhood behavior problems. There's even one advert that more or less says this drug could be useful for all the family. You know, you need to give it to your children because they're badly behaved, your elderly relatives, and you're going to be so stressed out with all these badly behaved children and relatives that you're going to need some too. By 1970, this is an advert for the same drug as the as the first advertisement I showed you. By 1970, note, it's being advertised as striking promptly at target symptoms, which are described as these disorders of thought, affect, behaviour and perception, i.e. psychotic-type symptoms. And it's being described as an antipsychotic. So it's starting to be portrayed as a specific, as a drug that can target the underlying disorder. There's a very similar process occurs with antidepressants. The first drugs that were thought of as antidepressants were actually similar. They were drugs that were used to treat TB, and they were similar to stimulants. They had similar effects to amphetamines, and the first articles about them make that quite clear. They describe how they could make people psychotic and very agitated and prevent them sleeping. But then they start to be described as antidepressants. They start to be portrayed as specifically attacking mood or depressive symptoms, and they start to be distinguished from stimulants, which by that time were gaining a bad name because they'd started to be used recreationally. So there was a need to distinguish prescribed drugs from them. So what happens basically is over the course of the 1950s and early 60s, there is this fundamental change in understanding of what drugs are doing. So prior to the 1950s, as I said, drugs are mainly understood according to that drug-centered model. As far as anyone bothers to try and classify them, they're just classified into sedatives and stimulants according to the sorts of effects the drugs induce. After the 1950s, they come to be classified and named according to the disease or disorder they're thought to treat. And the important point is that this transformation is not based on a lot of research or a lot of evidence that demonstrates that this is how the drugs worked. It's not even based on any analysis or discussion. It just happens, and when the disease-centered model becomes established, people forget that there was any other way to think about psychiatric medications. And the best way of seeing that is how the psychoactive effects of psychiatric medications have just faded out of the literature entirely. It is almost impossible to find any articles that describe the sort of altered state that you get with drugs like Prozac or Seroquel, the new antipsychotics, or Zyprexa. And almost impossible for me to get anything published on those effects. There is just, this can't be interesting sort of reaction. Okay, so how are we doing for time? So I'm not going to spend a lot of time on this, but in my book I go into quite a lot of detail about the deconstructing the evidence that might support the disease-centered model of drug action. And the most important thing, I think, to realize here is that the majority of evidence on psychiatric drugs and whether they're effective or not consists of placebo-controlled trials, comparisons of the drug with an inert substance. Those comparisons cannot possibly demonstrate that the drug is doing anything to the underlying disorder because, of course, there's going to be a difference. If you give someone something that makes them feel different, both physically and mentally, that's a completely different experience than just taking a sugar tablet or a chalk tablet. So they don't do anything to explain how drugs are working. Of course, the best sort of evidence would be if we had good evidence for what the mechanisms were underlying various mental disorders, and then you could work out from the mechanism how the drug might be acting on it, as is the case in many, not all, but many medical conditions. The trouble is, of course, we don't know this for any medical disorders. There are hypotheses which appear as if they might justify the action of drugs in a disease-centered manner, but they are just hypotheses. In the case of the dopamine hypothesis of schizophrenia, one of the best known of these hypotheses, the hypothesis was first thought of because people observed that one of the main effects of the early antipsychotics like haloperidol was to block dopamine receptors, to reduce dopamine activity. And therefore, because it was already believed that haloperidol was having a disease-specific effect, people therefore concluded, oh, well, if this is what haloperidol is doing, therefore the disease must be the opposite. The disease must be overactivity of dopamine. And that's exactly how the dopamine theory of schizophrenia was first came about. there really isn't any independent evidence for it, and there's even less evidence for the serotonin or monoamine theory of depression, which you've probably heard of. And it's now widely acknowledged by experts that there really is no evidence that there are any serotonin abnormalities in people with depression, even though that idea was so widely promoted in the 90s, particularly when the SSRIs were being marketed. I'll skip over that. The other evidence that might support a disease-centred model of drug action is if drugs that are thought to have disease-specific effects are shown to be convincingly superior to drugs that are not thought to have disease-specific effects. But it actually turns out to be quite difficult to find any evidence of this sort at all. So there are quite a lot of trials of other sedative drugs that shows them to have reasonably similar effects to drugs that are antipsychotics. There are two early studies that compared antipsychotics and barbiturates and did find the antipsychotics to be superior. But remember I said that Jean Delay and Pierre Denneker, who were interested in describing the effects of the early antipsychotics, they were particularly interested in distinguishing them from barbiturates. What they were saying is that these drugs produce a different state from barbiturates, which is more useful because they don't simply send someone to sleep. So the sedative action of antipsychotics and other sedatives is not necessarily equivalent, but in any case, there's quite a lot of evidence that benzodiazepines, well, there's many studies that don't really clearly distinguish antipsychotics from benzodiazepines, lithium or opium even. Lots of studies show that drugs that are not conventionally thought of as antidepressants have effects that are equivalent to antidepressants in trials that compare them to placebo or compare them to other antidepressants. Okay, I'll skip over that. So I'm just briefly going to try and flesh out what it would mean to take a drug-centred approach to the use of psychiatric drugs, and then to have a think about how we've got to the situation we're in. The first thing we need to know is we need to think of these substances as drugs, and we need much, much more information about all the effects that they have both in the short and the long term. And shockingly, we really don't have very good information on this for any class of psychiatric drugs. And then we need to work out whether the effects that the drug produces are useful in any individual's particular situation. Are they useful? Are they sustained if we're thinking of giving the drug long term? And, of course, crucially, do they outweigh the disadvantages that are inherent in taking a substance that alters the way that the body works? And I think that there are some circumstances in which the use of some drugs can be useful. So, for example, these are further comments on the sort of state that antipsychotics produce. Similar to the observations that Delay and Denneker made, people who've taken these drugs describe a feeling of physical and mental stagnance, a feeling of being emotionally suppressed. And although these effects sound very unpleasant, people also describe how these effects can be useful in suppressing intrusive and preoccupying psychotic experiences like delusions and hallucinations. But they're not selective. They're not simply suppressing the psychosis. They're suppressing everything. So I think this quote sums it up really well from someone who was on haloperidol, who said, although they felt very well, she felt as if she had nothing to talk about and couldn't remember what she used to find interesting. But she was very much in contact with reality, and that was, for her, in that situation, an advantage. Pierre Denneker commented that what he felt these drugs did was people just lost interest in their delusions. And that's why they were helpful. So for people with psychosis, I think the effects that antipsychotic drugs induce can be useful if someone's in an acute state. They can help reduce the intensity of psychotic symptoms and reduce behavioural disturbance. But there are many considerations, especially with their long-term use, which may outweigh the benefits that they can bring in that situation. And it's also important to point out that many people recover from psychosis. In fact, most people recover from psychosis anyway without drug treatment, although some people will go on to have further episodes. What about antidepressants? Well,